And here I just wanted to welcome you to Mobilising Exeter's Community Enterprising Spirit. My name is Daphne van Run, and I am co-hosting this session today with Nic Eversett from Canopy Community, who will be moderating the speakers part of the evening. Like some of you are already doing, please, while we're finding our seats and a few more people might be joining us, do use the chat to introduce yourselves while we're settling in. Thank you so much for creating time in your calendar, space in your minds to be here tonight. As you are aware, we are recording the plenary sessions of the plenary parts of this session. We will be uploading this recording on the Regenerate Devon YouTube channel to allow the people that can't be here to also engage with the content. So if you are not comfortable with that, please just have your video turned off or shoot me a message otherwise. I thought I'd give you a little bit of background information because some of you are here for the first time. We're here today with the third edition of Mobilising Exeter's Community Enterprising Spirit. But this project was really conceived as a response to the first lockdown. Colab Exeter, Exeter Community Initiatives, and Essence, Exeter's social enterprise network, they came together to join forces in understanding how we can best support communities during and beyond the current health crisis. These conversations over spring and summer between Colab, ECI and Essence, they resulted in a shared vision for mobilising Exeter's community enterprising spirit, and they can be summarised as follows. The key to mobilising Exeter's community enterprising spirit is not just in how communities are supported financially, it is more importantly about how they can be helped to connect and collaborate in order to meet the communal needs of a place. And through this, we achieve a joined-up approach that builds back better by solving what are often related social, economic, and ecological issues and challenges. So to bring this vision into practice and to start mobilizing in these times, we created an event series to gather people and organizations around particular themes. Back in November, we had the first evening on food, locally grown food, and access to healthy food for all Exeter residents. We then, in early January, we dived into inspiring and provocative examples on reclaiming indoor and outdoor spaces as a community asset. And today, the third edition on care in the community post-lockdown. In terms of enabling this piece of work to take place and bringing this to diverse audience, all free of charge, we are grateful to the Barrow Cadbury Connect Fund, who is funding this event series via SIMPL. So for those of you who are tuning in for the first time, maybe a slight context on, and maybe also those of you who might be newer to social enterprise, we might be speaking a lot about community and community enterprise tonight, social enterprise. So I thought I'd just give you a quick overview of what we mean with those. We are borrowing the terminology from Centre of Local Economic Strategies, CLES, when we talk about community. So a community is not merely a consumer of services, they can be a leader, an innovator, a wealth builder, and a valuable contributor, an important co-designer in policy decisions in the new economy. I will pass that on in the slide deck that comes to you afterwards. And by community enterprise, we really see it as a powerful vehicle for mobilizing community enterprising spirit. And what we mean with that is a social enterprise that trades within a geographical area or a defined interest group, and sometimes both. And that brings us to social enterprise. Quickly said, it's a business that trades to tackle social and environmental issues, improves communities and people's life chances. So tonight, we have a great lineup of contributors who share their ideas, experience and learning about reimagining care provision in the community. And because care is such a broad and complex topic, we wanted to focus tonight's conversations on care provision that includes, but not solely focuses on the care needs and opportunities that have arisen out of this current health crisis, but actually look towards recovery. And also care provision that can be co-designed and co-sourced from within communities, and therefore creating jobs and tighter communities. And thirdly, we wanted to make this conversation really, really relevant to Devon and Exeter in specific. And I have asked Paul to help sketch the landscape of this conversation for us. And Paul, who you might know is Paul White, Director of Essence and founder of Cclr Solutions. He has access to an extensive data set, which can be used to provide a good quantitative understanding of the system. He also has a great logical brain that is particularly well equipped for tackling complex issues. So Paul, if I start sharing my screen, could you walk us through the landscape?
So what is the poignant question? So Daphne, if you'd like to click the first element. I think one of the things we need to acknowledge coming into this, before pandemic indeed, is that we had a legacy care deficit, and I'll expand on that in a moment. But what we've got here is a definition of the demographic of Devon. These numbers do vary slightly. These are based on 2018 numbers, so there are later slightly higher numbers here, but in broad and in the main, it gives us a profile and an understanding of the different age groups. Daphne, if you mind clicking again. So on top of the legacy care deficit now, obviously we've got a new care concern emerging from COVID, and there's been some analysis now around the long-term effects of COVID are going to mean for us, and we're beginning to get a profile and an understanding of that. And then obviously, as Daphne mentioned, going beyond COVID and into recovery, we will be having to deal with the effects of the economic impact of pandemic, and of course Brexit's included in that consideration as well. So we've got a deficit in demand that we've highlighted, and if we look at where we were broadly before the pandemic landed, so if we look at health and care social spending, we had deficits in the region of 42 million in 16-17. The budget deficit increased to 49 million 17-18, and it's in excess of 50 million now, getting on towards 60 million in the latest numbers. So we've got this problem where we have a higher proportion of demand landing on services that we haven't got. We've got a gap in funding and spending for, and that's across the public sector. If we look at equally what the GSNA told us in 2018, we had a range of people with needs that weren't being serviced by the system. So as well as having the financial deficit, we were actually missing people from the system. And so some of the headlines in there are, loneliness, for example, in that older age group, 20% of people who consider themselves mildly lonely, 8 to 10% intensely lonely. And that was in 2018. So you can imagine that's before the pandemic landed. That will have increased. We had thousands of people that weren't being assisted in daily living activities. So simple things like getting dressed, using the bathroom, shopping. And again, we've seen that increase as the pandemic has hit and struck, and people have had to isolate. And I think alongside that as well, when we look at the numbers of people with existing health conditions, we had a deficit between what was registered on the GP disease registers against what the statistics were telling us was the prevalence that existed within our communities. And there's quite substantial differences in there. You can see, heart failure, for example, less than 50% of the people likely to suffer from that condition were on disease registers. Chronic kidney disease, another one, only 42%. And so that was in 2018 when we were struggling to meet and service demand. And obviously things have got worse since then. Do you mind clicking on, Daphne? In the worried well section in the middle group, we've got, still a large number of smokers. Obesity has been a problem and a topic of discussion in the news again in the run up to the pandemic. Physical inactivity, harmful drinking. So we've got a cohort of individuals in that middle age group that will be generating long-term health problems going into the older age group. So there is that need to sort of, address that within the solution, and we've been struggling to do that. That's more around early intervention prevention. And of course, when we talk about early intervention prevention, the earliest place to start is in children. And again, there were some, very concerning statistics identified in that 2018 public health analysis. So 13,000 children had a diagnosable mental health condition, but weren't able to find themselves into a treatment plan. So that was a considerable number of people that at a very young age developing a problem that was being left undiagnosed, which obviously then translates into an adulthood problem that carries on throughout their life if they don't get the interventions they need. 3,800 children registered as vulnerable, 12,000 having a physical learning disability. So these are very significant numbers pre-pandemic. Equally, when we look at the younger middle ages, estimated asthma sufferers, diabetes and epilepsy sufferers, quite considerable numbers there that again were not all appearing on the disease registers being managed by GPs.
Well, you're into your last minute now.
Okay, so in the new care category now, things that are started to come through, 1 in 5 respondents testing positive exhibit symptoms for quite long periods of time after they've been diagnosed, so 5 weeks or longer, and then 1 in 10 exhibit symptoms for up to 3 months. So these are now individuals that need additional support as they hopefully traverse towards recovery. And if we move on beyond those particular statistics into the future needs, so carrying forward all the deficits that we had before, we now have other concerns around long-term chronic condition numbers increasing as a result of COVID, around thrombosis, heart failure again, kidney injury, COPD, those and lung conditions. So we have a likelihood that the deficit's just going to increase, and obviously we're still running with austerity as a challenge, and clearly the financial and economic challenge is going to continue now as a result of the impact of the pandemic and subsequently the consequence of Brexit layering in on top. So we have a high set of demand out there that we need to, and could look towards how we can find different ways of servicing. So that's a scene set. That's very desperate. We're now moving on to the more positive aspect of the evening, which is some of the ideas and things that we can do actually about this.
Thank you, Paul. Thank you for that. Yeah, pretty gloomy picture. A Devon picture. Like Paul said, it's very broad, it's very complex. And now we are going to talk about tonight's contributions. Because this series has been designed to actually give stories of regeneration and hope. So that's what the focus is for tonight. Tonight, contributions of Hilary Ackland, Nina Parnell and Michelle Pryor. They have a common thread. They are about bringing new ways of organizing care into our communities where clients get a better deal, but so do the people who provide the actual care. I will just stop sharing my screen for now. So without further ado, Nic, I will hand it over to you to take it away.
That's great. Thank you very much, Daphne. Yeah, we're very excited because I think we've got some, as Daphne said, 3 very, very interesting, exciting presentations. And I think by actually giving different aspects of the whole care issue and also what we can do about it. So, so just to let you know that the format is the same as last time, which is our presenters give us a 5-minute presentation, and then we'll have 5 minutes Q&A to ask them a few questions about what they're doing and maybe their next steps. I do prioritize any questions you have, so over the ones I have. So if you want to put some questions in the chat, I'll be monitoring it, and so will Daphne, and we'll jump in with your questions for our presenters tonight. So, well, without further ado, let's move into our first presenter for the evening. This is Hilary Ackland, and she's a councillor at Devon County Council, and she's had experience with care and domiciliary agencies throughout Exeter for a long period of time. So we're very welcome. Thank you very much, Hilary, for being with us tonight.
I'm going to talk to you tonight about a very focused aspect of care, which has concerned me during the time I've been a county councillor. I've been a county councillor for the last 4 years. You probably know elections are coming up. And I can see from the people in this meeting that you're all really, you know about care. And some of you are very involved in social enterprise and cooperatives as well. So this is really at the centre of what I want to talk about. The big problem, I have been on the Health and Social Care Scrutiny Committee as the Vice Chair. And so I've been at the centre of challenging what's going on with social care and trying to make sure it's as good as it can possibly be within Devon County Council. And I've been very concerned about the workforce issues in domiciliary care and the way that domiciliary care agencies have been operating, and the pretty bad working conditions that care workers work within that system. The care agencies are take quite a good chunk from the contracts they get from Devon County Council, but the care workers are generally working for minimum wage or living wage and very low. And we've tried very much to try and raise that and make sure they get at least £10 an hour. But what has interested me was that there's a whole number of people working out there who don't work within the system in an unregulated way, and these are the personal assistants. And in getting to know about these personal assistants, I found they're absolutely amazing people. They do a really fantastic job with people who can afford to pay to have them, because Devon County Council doesn't really interact with them very well. And so even people on direct payments find it very, very difficult to get support through Devon County Council to find their own personal assistants. The system isn't working well at all. So in discussions with these PAs, I finished up, I can see, and having some kind of vision about where we could go in the future with this. Because the thing that I got to discover about these PAs, that although that you might think they work on their own, because they are self-employed, because they run their own systems, and many of them do that now because they got so fed up with working in the agencies and not being treated properly. They had a kind of resilience and an imagination, and they got off their back and they became self-employed and are running their own lives, and they love it, and they feel they can operate in a very flexible way with their clients. And that's something that shouldn't be lost. It should be built on. And what a lot of them have done is they've got themselves into little groups, little informal groups where they work together. One of them sort of takes the lead and brings others in, and they manage their clients in a very informal way. So it struck me that if we could get that in a slightly more organised way, then it would actually help with their communication with Devon County Council and have more of an opportunity to work with people who are involved within direct payments, who could then choose to have these PAs, and with support from Devon County Council on that side of things. And on the other side of things, the group working together could maybe find a way in which they could consolidate that in a way and operate less informally and more efficiently together. So I went on a bit of a research hunt to find out what was going on in other parts of the country, and I discovered that in Somerset there was a community catalyst project and program where these sort of people were involving themselves in what they called micro providers, and creating groups of micro providers where they were supporting one another and engaging with one another. And these little micro provider groups were then getting themselves in a position where they were in a better position to fulfill the unfilled care packages. And that is was going on in Somerset and is now going on in Devon. And I discovered that by using these micro providers, Somerset County Council was covering their care packages and saving £1 million a year working with, because these PAs are not charging as much as the care agencies, but they're getting a decent.
1 more minute.
So what my vision is that to bring these micro providers together in a setup with a cooperative platform in which they can then support one another, and that platform would become like a portal that would be able to then operate with Devon County Council. So that's the kind of general gist of it, but please do ask questions and I can fill you out a little bit more.
Very good. Thank you very much. Yes, we do have a question from the audience, which is maybe a clarifying question, and it's a good one, which is, what are personal assistants as opposed to carers? Are they the same thing, or are they different?
Personal assistants are the name given to care workers who are paid, who operate in a self-employed way, and they have a negotiating contract with the client. They directly work with the client, so they go. The client finds them, and they discuss together how many hours they do, what kind of caring they want, and what they're going to charge.
Great, thank you very much. So actually, Michelle, do you have a question?
I think I just wanted to clarify that personal assistants are unregulated providers, so they're not regulated by the Care Quality Commission, by CQC. But they can work either self-employed or they can be employed directly by the client, as I understand it.
Yeah, well, they are self-employed.
Unregulated.
Yeah. It's the unregulated market because but that doesn't mean that they are untrained or non-professional or anything like that. Many of them, they do work and they develop, they train themselves.
I completely agree with you, Hilary.
And the idea about the platform would be to help them coming together, that would then encourage more training and development.
Yeah.
So Henry, what do you think?
Does Roxy want?
No, go ahead.
Sorry.
No, Roxy made a comment. I mean, so Gareth has asked, should we have a national care service like the National Health Service?
No, I don't know. But what I found, I'm not going there.
Mm-hmm.
Where I'm going is, what I discovered about these care workers are that they want to operate as independent individuals, acting like a friend to these clients and having an ongoing relationship with them, which doesn't happen in care agencies because people keep changing and moving around. There's a sense of ownership and responsibility that comes with you having a direct relationship with your client that is, the value in it is priceless, and it's a different order of activity. So I wouldn't want to lose that.
No, and so I mean, at the moment, what do you think the first steps are in realising your vision? What would you?
Well, there's two ways of looking at it. One is getting a lot of support from the cooperative movement. I know what's going on there. I know that there are different models that have been tried in different parts of the country, like the Colne Valley model in Yorkshire. There's a learning disability cooperative model. There's the one that is closest to the sort of thing I'm thinking about is Equal Care Co-op, which is like a platform. They're operating like a platform. And the key thing about the platform is that the platform isn't some sort of setup which is separate from the PAs who form these micro providers. If you can imagine lots of little circles, and all these little circles are all joined together within one big circle, and that big circle is what's giving them support and structure. That's the kind of model, and they own it. They're members of it. They're a cooperative. It's theirs. They're in charge of it. That's where the vision is going.
And I guess the big point here is that, or one of the big points is that they actually get a lot more of the value of the contract instead of it being sort of top sliced above.
The contract would come into the co-op and would be, and it would be not for profit. Anything over and above would go back in and feed the system.
So in terms of sort of local government, up until now, local government have seemed to be very keen on sort of outsourcing everything to sort of big organisations, managers rather than providers. Do you think there's more willingness now to maybe change that model? Exactly.
I've been in discussions with the committee. They've set up a board to look. They're really interested in this. They're going to put a bit of money into the community catalyst idea. And there's a genuine interest now, after banging at the door for 4 years, for them to actually, I think there will be some movement in this area. And I think if this gets off the ground, and this has got to come from the ground up, from the PAs themselves, and that's where all the energy will go, that you can be a facilitator. I can help facilitate this, but really it's up to them to make it happen. And they're keen, and it's just helping them and facilitating them to find a structure in order to get this off the ground. And I'm starting it, I would like to get it going in Exeter, first of all, because in Exeter, there's a tremendous need to cover these care hours. So the local authority are really keen for something to happen so that they can cover these hours.
Yeah, totally.
And this might be a way to do it.
I see Roxy's put something in the chat which said, I'd love to see an event like a community assembly that hears from care staff and from clients in care about their experience, coupled with a vision and alternative models that perhaps kick off varied interest in setting up these things. Yeah,
it'd be fantastic to, because ideally you want your clients as well, especially ones who need care and support and personal assistance long term, to be members too. There's nothing to stop them being members as well. Ideally, you want them both, membership to be with the client and with the so they all have a say in how their care could be organised. It could be amazing, actually, and it could really make the whole care business, I don't know, so much more, give quality of life to people who need care, as opposed to just getting care and it not really giving them the kind of quality of life you want them to have.
Yeah, and I guess the caregivers who are able to actually provide the care at a living wage. I have to say, as a good Labour person, it really bugs me that the people who can afford it get the best care, because they can pay for it, and they can pay for people to come in and give them everything that they want. Why should it just be people who can afford it? It should be everybody. So unfortunately, we come to the end of our 5 minutes of questions. One question I did want to ask you is, before we go, is there anything that the group that's here, or anyone who watches this back afterwards, because a lot of people do watch it back afterwards, can do to help you move this forward, Hilary?
Really, I'd be interested to talk to people who find it interesting. And who are in this business, would find it interesting and could help them get it off the ground. That would be great.
Fantastic. Thank you so much. And just to say that we will have optional networking at the end of this event, and Hilary's agreed to stay on. And if anyone would like to talk to Hilary a little bit more about her ideas, then please join her for the networking at the end. Could
I just make one point, because somebody is asking about the national care. A national care system. The thing about a national care system is it could be like a national health service, in the sense that there was equality, and free at the point of need. But whether that is actually going to happen or not, we don't know. The government, this government, every government, is taking forever to come to any understanding about social care, and also the cost of it and the amount it would cost and so on. But this project, the way I'm looking at it from the ground up, is not antithetical to that. That would be part of a integrated care system, part of the whole system. And yeah, of course, it would be wonderful if we had a decent, across the board, national care service, like we've got a national health service. Obviously, it all should come together.
We've got to work with what we got.
Yeah.
Yeah, thank you so much. Thank you, Hilary. Yeah, really interesting chat and conversation here. And hopefully the conversation will continue from now on. So moving on to our second guest today, that's Nina Parnell, and she works for Westbank. Is it Health and Wellbeing? Is that right? Wellbeing and Health. That's right. I can remember which direction it was. So, and you're head of volunteer services. Is that right? We got. Still can't hear you.
There we are. Sorry. Hi. Sorry. I'm head of volunteering and community services.
Fantastic. And you're going to talk to us about, well, maybe some other observations in a minute, but mainly about an initiative you want to put together called 100 Working Together. So,
that's right. Yeah. Thank
you.
Welcome,
Welcome, Nina.
Thank you very much. Throughout the last very difficult year, Westbank, like so many other charities across the country, has played a vital role in our community, helping to protect and support the most vulnerable. We've got an army of volunteers who've provided over 10,000 acts of kindness during that time. I've been humbled by their amazing responses to people's needs during this really difficult time. So now we're starting to move forward and starting to plan for the future. And so what we have to start thinking about is how we're going to harness that support to take us forward and to help those people's lives have been affected by the pandemic, and really start thinking about what are those needs. There are going to be so many. What do we do? Who do we help? And how are we going to do that? So for me, we've been thinking about it. And for me, one of the biggest issues that we need to tackle is that around loneliness. How are we going to make it work? How are we going to help people and support them through loneliness? Just to set a bit of a context, 2 or so years ago, a colleague of mine went to visit someone living at Budley Salterton, who told them that every time she got out of bed in the morning, she started to cry because she knew it was another day that she was going to spend being lonely. At that point in time, we didn't have a volunteer to help her. I reached out to a number of other volunteer organisations. They didn't have a volunteer to help her. So we launched a bit of a campaign, and we sent out 23,000 leaflets right out across the Exmouth area. It yielded nothing, not one response, not one volunteer, nothing.
Wow.
And now I believe that if we sent those leaflets out today, everybody would get loneliness, because at some way or another, we've all been there in this last 12 months in various forms, but I think people would really understand that. So as we get a green light from the government to start moving forward, for most of us, we'll leave those feelings of loneliness behind. But what about those people that can't leave those feelings behind? What about those that just haven't got an option in their lives? So people like Frank, an 87-year-old gent who was referred to our service back in November, his wife of 63 years had died at the start of the year. And because of his limited mobility, Frank hadn't been out of his house since February. He went for days and days and days without speaking to anybody. Following the referral, he's become part of our Westbank family, and we're supporting him as best we can through the lockdown, and I've got lots of plans to help him as we come out of lockdown. When I first met Frank, he told me he thought he was going to die of loneliness. Now, surely that's an exaggerated statement. People don't die of loneliness, or do they? There's now substantial evidence that having a lack of social connection significantly increases the risk of death by 26%. The effects of loneliness are comparable to other well-known risk factors such as obesity and smoking. And loneliness isn't just something that's experienced by older people. Research also highlights that young people aged 16 to 24 are feeling more lonely than often older groups. And there's also a link to suicide. I recently learned of a case of a 24-year-old man living in our community who took his own life for this very reason. These are preventable deaths in the main. They don't require vaccine or drugs or expensive medical interventions. What they need is an act of human kindness from volunteer befrienders, people that will go and sit and have a cup of tea with them, go out for a walk with them, or in a younger case, maybe a gym buddy. And it's such a cost-effective resource. So, however, volunteers are, there is a cost to providing that service. They need training, they need support. We need to go and check out homes to do risk assessments and things. But it's really difficult to raise funds. The big lottery are just about to put out £1 million to support loneliness. But that across the country, you know, it's a drop in the ocean, very difficult to get. So what we've come up with is an idea that we would like to launch a local service, and it's 100 working together to combat loneliness. And we'd like to reach out to local businesses to donate £500 each, 100 businesses that would help us to launch a service, get a programme manager, train and recruit an army of volunteers to serve across Exeter. I'm not asking you to donate this evening. I'm just market researching. What do you think about that? Is that a good idea? Do you think that's workable? We have got to start thinking outside of the box a bit if we're going to tackle this. No one organisation can do it on their own. And I just think it's such a great community initiative where we could all work together to move this forward. And really, I'd just like to hear your views on that.
Nina, thank you so much. That's really great. So I'm just if there's any comments or questions you have for Nina, please put them in the chat now and we can kind of respond to them. So Nina, obviously I'm just kind of interested, obviously this has come out of the kind of wider work that you're kind of doing within Westbank. So what have you noticed from your team's perspective in terms of the work they've had to do over the last sort of 6 months at least?
Okay, well, we've been incredibly busy. You know, as I say, we've dealt with more than, I don't know, with 10,000, 12,000 acts of kindness. That's from shopping, prescription collections. But what we're noticing now is through the first lockdown, you know, the nicer weather was there, and we were able to support people with telephone calls to keep them active and engaged. But this time it's so difficult. People are absolutely at their wits' end. They're spending days and days in their houses, unable to go out, no family are unable to contact, and it's really difficult. We can run support groups, but we can only have 15 at a time. There's a limit to what you can do, and there's a limit to the way in which you can support them. So our concern is this is going to be a massive problem as we move forward, and how on earth are we going to support that? Because, you know, they don't need regulated care. They need companionship and a purpose, a bit of structure to their lives. So it is finding ways that we're gonna help them.
That's really helpful. I noticed Daphne's asked a question, which is, can you say a little more about the sort of better triangular relationship between the statutory services, volunteers and care services? Because they all work together, don't they? Yeah,
of course. I think the pandemic's been extremely difficult, but from a working perspective, it's brought about such closer working relationships from those people, from those organisations working in communities. So we've built a much better standing within our community. We work much more closely with district nurses. Hilary's been talking about unregulated care providers. We've had a catalyst company, if you like, set up in Exminster. So between ourselves, the community nurses and the care providers, we've got this great triangle going now where we all refer between each other to best support those people, the most vulnerable. So if, for example, you've got someone that's getting someone in to help them wash and dress, but they're also a bit lonely, then we can put a volunteer in and do something. Or if we've got a volunteer going to see someone that's a bit lonely and we notice they've got a problem with their health, then we can make a referral into the nurses or the GP. So it's a really good triangular sort of referral system, and it works really, really well.
Fantastic. I just noticed that Daphne's just put your contact details in the chat. So if anybody wants to contact you, they can do so. So just pointing people in that direction. So what do you think, assuming you get the positive sort of feedback about the whole idea, what do you think your next steps are going to be in trying to move this forward?
Yeah, so what we'd like to do now is, if we get positive feedback, as I say, it's something that we've not tried as a charity before, we're going to make a bit of a film with some people that have experienced loneliness to get the message across, and then we're going to start contacting businesses and launch something across social media to take it from there. So yeah.
Well, for me, it sounds like a great idea, and I think there should be a lot of organisations that would be willing to sort of join together with you. I certainly hope so.
Yeah, I hope so. I'm really conscious, Nick, that £500 is a lot of money for some businesses, especially smaller businesses that have been struggling. But just as there are those that have been struggling, there are those that have actually continued, to
done pretty well.
And yeah, that's right. So I think that will be our target of where we'd start looking to start with.
So in terms of what can we, the same question I asked sort of Hilary, what is it that we could do, or the people watching back could do, to kind of help you move this forward?
Okay, well, first of all, I'd value your opinions on whether you think that would work, and that if you're happy to email me, and sort of start collating names, so that as we launch the appeal, that I'd reach out to people and just think about ways in which maybe if you've got a business of your own that you could support. Of course, it doesn't just have to be about money. It could be that your staff could volunteer. And I've been speaking to a gym owner who wants to create a community within his gym. So there's, there are various ways that we can work together to make this happen.
Actually, I've noticed a question which may be slightly off topic but relevant. It says, is Westbank hoping to, this is from Grant, sorry, is Westbank hoping to reintroduce walking for health services in Devon?
We certainly are. We certainly are. We're doing one-on-one walks at the moment for people that are really struggling. But yeah, I think we'll look to increase those most definitely.
That's good news.
Yeah.
Because I mean, that's such an easy way to help loneliness, isn't it?
Absolutely, Nick. Yeah, it is. And when you're out walking with someone, it's almost like, because you're not looking at each other, it's almost like a bit of a counselling session as well, that you get to talk about all sorts of things. So yeah, it's good.
Will looks like he's got a hand up for a question. Will, do you want to fire away?
Yeah, just a suggestion. I'm sure you're aware of the money that Exeter Council's won from Sport England through the local delivery pilot to encourage people to live more active lives. That might potentially be a good source of funding for you, because not only, obviously, through walking, you're getting people physically active, but there's also the benefits of tackling loneliness as well. So there's 20 areas across Exeter and Cranbrook that they're looking to target. So that might be a good route for you to access to get some funding, because they've got millions and millions of pounds to invest in pilots and test programs.
Okay, thank you. I'll make a note of that. Thank you very much.
Great, thanks very much, Will. Thank you, Nina. That was very interesting, and I'm very excited by it, and I wish you all the best with your endeavours with the new project.
We'll keep you posted, Nick.
Yeah, thanks, Nina. Great. So, well, on to our third guest for this evening, and I'd like to welcome Michelle Pryor. Hi, Michelle. How are you?
I'm fine, thank you. Yeah.
Very good. So, and you run something called TLC Palliative Care. Is that right?
That's right. It's a startup, so I'm not actually trading yet, but I'm hoping to start trading quite soon by launching a carer introduction service. So it ties in with what Hilary is talking about.
Right.
Do you want me to start now?
Yeah, please share it with us. Yeah, you've got 5 minutes.
So why have I gone down the route of creating TLC Palliative Care at Home? My background is as a hospice nurse, supporting people who wish to stay at home at the end of their lives. It's a difficult topic to talk about, so I'm just going to jump straight in there. But most people who have a life-limiting condition want to die in their own home, surrounded by their loved ones. And as their illness progresses, they become more dependent on others for social care, first of all for household tasks, and then later on for their personal care. Where do they get this care? Informally, family, friends provide a huge amount of care, but later on in their illness, they will probably need to get social care providers, usually a domiciliary care agency. Mostly they have to self-fund this care unless they fall below the social services threshold up until the last few weeks of life, when they may get continuing healthcare funding, which picks up the care costs for an average of 3 hours out of 24 a day. So even when somebody's actually dying in bed, that's all the care that is provided on the NHS, apart from trained nurses. So that leaves about 21 hours to be covered by the family, the NHS visits from nurses, other healthcare professionals. At this time, families are coping with anticipatory grief, and it's a very intimate, personal time. And what they want is they want personalised care for their loved one, tailored to their preferences. They want people who will respect their home and their privacy. They want as few different individuals coming into their home as possible, because when somebody's dying at home, their home becomes Piccadilly Circus, typically. They want kind, compassionate carers who have time and who have the right skills and experience. And they need it to be affordable. Care agencies charge probably between £25 to £30 an hour now. personal assistants tend to charge between £12 and £15 an hour. Families often need blocks of time at this stage because they don't just need half an hour, they need somebody to come for a couple of hours, particularly if it's to give the family carer some respite or overnight sitting. So the challenges in finding care for families are care agencies often don't have capacity to take on, particularly when somebody's actually reaching the end of their life. They're very intensive care packages for a few days. They're unpredictable. They can be 2 carers 4 times a day and some night sits. The carers that come, if they're trained by ordinary domiciliary care agencies, training is not usually a high priority. There's not that much mandatory requirement for training, particularly in end-of-life care. So they can have carers coming in who maybe don't inspire confidence in the family, that they know really what they're doing in this situation, which is very different from general social care. Families might want to find a personal assistant to help address some of these problems, but that can be daunting because they may have to actually become employers. So I saw this as a hospice nurse. I frequently get asked, can I recommend a carer? And I have explored it with hospices. I've explored it with NHS colleagues. Nobody can pick up the extra tab of taking on social care. So I feel the solution is to set up a specialist not-for-profit care agency for palliative and end-of-life clients. So it would be a specialist care agency, and I haven't found another example, which will bridge the gap, if you like, between hospice provision and general social care. So we aim, TLC Palliative Care at Home, CIC, aims to become this. The first phase will be launching a carer introduction service. And how I will make that pay will be a commission charged on top of the carer hours. So all care hours that are agreed through TLC's carer introduction service. Say that the carer charges at £12.50 an hour, then TLC would charge a 20% commission, which is what would pay for my time in setting it up, and also would put a small amount of money into a pool that would enable us eventually to move on to phase 2, which will be becoming a CQC regulated provider.
One more minute.
Cost to that. 1 more minute. Okay. Yeah. So we would continue to work with personal assistants once regulated, but we could also employ carers to deliver the CHC funded packages of care at end of life. And if this is sustainable, phase 3 will be spreading the word and enabling other organisations to meet this very, very important need. So the carer introduction service is step 1. I hope it will grow a pool of carers and fund the next stage of development. What do I need to facilitate TLC's care introduction service? Carers who would be interested in working as part of TLC. So if anybody knows carers who have a particular interest in supporting people towards their end of life in East Devon, please get in touch with me. We will need clients, but I think they will come through healthcare professional referrals. And we need, yes, supportive healthcare professionals, palliative care providers and community support organisations who will be interested in what we're doing and supporting families. Thank you very much.
Thank you so much, Michelle. That's so. I mean, it might sound obvious, but I'd like to ask you anyways. What I mean, I know you've worked in the palliative care, but why set up TLC? It's not easy setting up these kinds of things, is it?
Not at all easy.
It's a labour of love, really. And so
I think it's just born out of a feeling of such empathy with families, because what happens is if the care isn't there in the community, then people might be admitted unnecessarily to hospital when they don't need to be there medically, but there's carer breakdown at home or they can't get the right care. So they go in or into residential care. And worse still, they can be stuck in hospital no medical reason to be there, but they can't be discharged because they can't find providers for a package of care. And that is a very common problem, that people stay longer at a time when their lives are very short. You know, there's only a few weeks ahead or days. So that is a tragedy, really, that they're stuck in hospital. So hopefully that's what drives me, is wanting to see a different way of providing care at end of life, rather than just, and I don't mean to knock domiciliary care agencies, they do a fantastic job, many of them, but the whole way the care is organised and funded doesn't seem right. And I agree with Hilary that I think there is a better way of doing it by using personal assistants and helping them to support each other and work cooperatively. So that's my idea.
Nia, do you have a question? You need to unmute.
I say I'll get used to it one day. Michelle, I just wanted to say, I think it's absolutely brilliant. I think there's a definite need for what you're providing. One of the services that we manage is something called Neighbourhood Friends, where we facilitate discharges for people that don't have family and friends to help them as they go home. And we are, I'm not saying it's a daily occurrence, but we get asked a lot to provide volunteer support to help in a lot of these circumstances. And the thing is that things like this are above and beyond the volunteer. We're there to help facilitate, do a bit of shopping or whatever. But it is. So we would really welcome this. And I'm sure we would be referring to you a lot. It's definitely needed. So, yeah.
Thank you.
So obviously, I think I read on your site actually that the number of percentage of people who want to be at home to die as opposed to being in hospital or a hospice is very high, and not everybody gets that opportunity.
About 80% of people who are in that situation, when asked, would say they wanted to die in their own home, and that might be in a residential home, but actually in Devon, in people's homes in the community, I think I'm right in saying it's only about 20% that achieve it. Over 50% die in hospital, and that is the tragedy. Because that hospital is people's least preferred place to die on the whole. And a lot of people opt to die in hospice, but the hospice only has 12 beds in Exeter, and only about 5% of those people die in the hospice. So it really, the community is the right place, but we need to put a lot more of support in place to help that to happen.
So Chris Gunson has asked about training.
Yes.
So would you train the carers in end-of-life care?
So well, I say yes. I mean, nursing somebody at end of life is actually usually just good basic nursing care. So it can be taught relatively easily. I would definitely aim to provide informal teaching. I would support our carers in doing the care certificate, and there are some very, very good end-of-life modules available on Skills for Care. So that is one of the ideas, and also that we would hopefully be able to provide practical training on things like manual handling, those kind of things, how to use the nursing equipment that is available through the community, through the NHS, that every patient can get. But not all carers are trained in how to use it. So how to safely move and handle somebody who's being nursed in bed, that kind of thing. So yes, I would aim to provide training. But the trouble with the care introduction service is that CQC are very they limit what you can do very, very tightly. So you can only act like a dating agency between the carers that you recruit and the clients that need the care. And then you are really not allowed to oversee or direct the care. So what I want to do is, as soon as I can afford it, is to become CQC registered, still carry on working with those personal assistants, but actually be able to provide more support for the client as well as for the carers. And something I'm very interested in, and I think Hilary and I might have a dialogue about, is the idea of seeing whether there's any possibility of working with CQC to try and get sort of umbrella status for carer introduction services, so that self-employed carers or personal assistants can actually be CQC regulated, because then they could group together and actually provide at end of life. People need 2 carers at once, not 1. And that is very difficult at the moment for personal assistants to provide, because they need to be able to work in pairs. So I think that would be a really huge step in the right direction. But at the moment, CQC don't allow it. You either have to be unregulated and you can only introduce people, or you're regulated with all the constrictions that, or challenges that brings to.
Thank you so much. I'm afraid we've kind of run out of time. It's been really, there's so many questions to ask and there's so little time. So fantastic presentation. Thank you very much. I wish you all the best with it. And one of the things I think we didn't quite get around to was just thinking about whether it's a model we could actually, maybe once you've worked it out, that it could be actually replicated in other areas as well going forward. That would be very exciting. And perhaps that's something we could pick up in the chat, in the networking afterwards. So I'll just hand back to Daphne now.
Brilliant, thank you, Nic. Yes, so we had 3 stories, 3 different angles on looking at and reimagining the care provision from a community perspective. Of course, I am biased, but for me, tonight has confirmed again that the social business model lends itself very well for initiatives active in health care and well-being. We're wrapping this evening up. From a Mobilising Exeter's community enterprising spirit point of view, it takes a continued commitment to dialogue and joint action with all sorts of organisations across Exeter and beyond to truly establish this joined up approach between various organisations within the voluntary community, social enterprise and charitable sector. We will try and facilitate that through these events. I will post a link shortly to a platform called groups.io, where you can join our friends from the Regenerate Devon Summit and continue to stay in touch and take conversations, ideas and collaborations further. Then I want to do 2 shout outs. Perhaps you'd like to join the social enterprises active in the health care and well-being sector that are joining Essence. I will post a link on Friday. They're meeting again in a sector-specific focus group. These occur monthly. That might be something for you. And I just wondered, Nic, if there is already a next demo night scheduled that you can introduce people to.
Yeah, I mean, for those who don't know what demo night is, it's an opportunity for people to actually showcase startups. It's slightly similar to what we've done tonight in some ways, but in all sorts of startups. And I run a network that just helps entrepreneurs and startups kind of get started and avoid failure, basically. So we have a monthly demo night where people come along and just showcase what they do, and it's often very interesting. So if you want to come along, please do.
Yeah, I'll post that in the link as well.
Thank you.
In a minute. So yeah, thank you to all of you. I know that we should have had a few more people, but there was some trouble getting into this space. Hopefully they can see the recording. Please stay on. If you like to wave off, feel free to leave the meeting, and otherwise we'll see you hopefully next month again for the 4th edition of Mobilising Exeter's Community Enterprising Spirit. So many thanks, and just have a short break, 2-minute break for the people who would like to stay on for the networking, and we'll be back in 2 minutes.